Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show host or the guest are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. We recently celebrated World MS Day, and this year's theme was bringing everyone affected by MS closer to people involved in MS research. And that's exactly what we try to do weekly here at MS&Me Interviews. And in celebration of that, we would like to do a review of some of the fascinating clinicians and researchers from around the globe that we've spoken with during the past year, and in hopes of letting you know that they are indeed striving for better clinical care and working toward that cure and better treatments for MS. Enjoy.
Jacqueline Nicholas is a board-certified clinician, immunologist. She entered the field of neuroimmunology. She is dedicated to providing personalized care to each patient and their family.
My goal was to enter the field of MS to provide better care and to help people live their lives as full as they possibly could, but also trying to do research to advance the state of care for people with MS. And my goal is eventually that we'll have a cure for this disease.
That's amazing. I know that must be fascinating to be involved in actual research as well.
Absolutely. I mean, even in the time, that I've been practicing, we've come out with a significant number of new treatments, and each new treatment that we've come out with has even more amazing effectiveness. And so, the hope is that long term we'll be able to determine, what is the proper treatment for somebody initially, and based on some type of blood test that'll say this is the medicine for you and this is what's going to fight your disease and work best for you. I work in the MS Center at Ohio Health, and it's in Columbus, Ohio, and it's a pretty amazing place to work. We have three of us who are physicians that care for patients with multiple sclerosis. And then there are also four different nurse practitioners who specialize in MS as well. And then separate from the clinical care providers who see patients at every visit, we also have a neurophysical therapist who's there in the clinic every day to really provide her advice for free and to help to provide people with input. So, for instance, if somebody comes in and they're having, problems with strength in a leg, they may come and evaluate them and say, I know you're exercising a lot, but here's some exercises you can do to try to really work on that, or, any kind of splinting need or device needs. And then we also have speech therapists who are there if anybody's having any trouble with swallowing or memory and thinking or speaking. They're there to be able to come in and meet with the patient. There's also occupational therapists who are really there to help if there are any issues with activities of daily living. And so that's been incredibly helpful. We have a MS specialized social worker who is really just there for MS patients. She doesn't work for any of the other clinics. And really she's remarkable in connecting people with resources, whether that be in regards to work, setting up a better work environment, or somebody who perhaps needs to take some time away from work. There is a large infusion center connected to the clinic with several specialized nurses who are very familiar with all the infusible MS therapies and steroids. And so that's right there in clinic. If somebody should come in with a relapse and need steroids that day, they could receive it. There's also an actual physical therapy gym in the clinic, and it's not a huge gym, but it's a space where if we really need to do more intensive training in depth, the patient can go back there with the physical therapist and work on that particular issue. And then we have a patient education center that is right outside the clinic, and it's available so that we can run our patient educational events and support groups. So we do a lot of clinical trials, and anybody that comes does not have to be involved in a clinical trial, but I think that it's a really neat option because some people are really interested in research or getting something that may be the next best thing for MS. And
what specific symptoms can a patient control or reduce with like an anti-inflammatory diet?
So, it's interesting. There's been so much talk about this, and I'm fascinated by diet because I think that it really does make a difference. And, the problem is that a lot of the research has been done, but it's not been done in a very controlled manner. And obviously this problem is that we're all humans, and if we're told, stick to this particular diet and we're going to study you, I don't know, I would cheat and I'd be like, I'm going to eat that chocolate brownie even though I'm supposed to eat fish and nuts. So, that's always been a challenge. But I think there are a lot of symptoms that are affected by diet, and fatigue is one of the biggest ones. And we know this from not only MS, but also from other disease states, that if you're eating a diet that's high in processed foods and not really getting those fresh vegetables, fresh fruit, whole grains, you may be somebody that your fatigue is compounded by what you're eating, or a diet high in sugar. And so, there has been a lot of look into this. And I think most recently, I was really happy to see that there's been a lot of media lately about some of the studies that are looking at diet and MS. And I think probably the most notable recently has been discussions on the Mediterranean diet, which is, high in fish and omega-3s. And so I think it'll be really interesting to see what the outcome of those studies show. But I do know that I have, many patients coming in who always ask, is there a diet that I can eat or abide by that's going to help me fight my MS? And so right now, we don't really know the answer to that. We haven't seen any good evidence that it's going to prevent damage in MS. But we do know that people come in and they say they found a particular diet and they feel like their energy is better, or they feel like they don't have as much fatigue. They're thinking more clearly. They even just feel better overall. And so, in answer to the question in regards to symptoms, I think fatigue is probably the biggest one. I think it's really hard to say about other symptoms, although one of the things that is being looked at in some of these studies is whether it helps with decreasing pain levels.
Today's interview is with Scott Montgomery, professor at Örebro University in Sweden. Welcome, Professor Montgomery.
Thank you very much.
Your study was published in the Annals of Neurology, and it comes from a collaborative study between Örebro University and Karolinska Institute, which showed concussion in adolescents increased the risk of MS in later life by 22% for one concussion, and teenagers who experienced 2 or more concussions were at more than a doubled risk of MS at 133%. Now, how does a concussion initiate the process of multiple sclerosis?
I've seen evidence from some experimental studies that show injury to the central nervous system, both the spinal cord and the brain, can begin an autoimmune process where the body's own immune system starts to attack the tissues like the myelin surrounding nerves in the central nervous system.
Do all teenagers who've suffered a concussion run this risk of developing multiple sclerosis?
No, because multiple sclerosis, we know, involves an interplay of both genes and environmental exposures. A very small percentage of the general population carry the genes that predispose them to multiple sclerosis. So most people who have a knock on the head as a teenager are not at a huge risk of developing multiple sclerosis.
Well, why do adolescents under the age of 11 who suffer the head trauma have less of a chance of developing MS later in life?
Well, this is a question of speculation as well. Why children don't seem to develop MS if they have a concussion? Well, childhood and adolescence represent different stages of brain development. During childhood, there is rapid growth and synapses, connections between neurons are being formed, and there's probably greater scope for repair if there is damage. Whereas in adolescence, that's a different phase of development. There is a pruning effectively. So the brain may have less scope. There's also a question of severity.
And if you is with Dr. Chase Spurlock, CEO of iQity, developers of the Isolate MS and RNA blood test for multiple sclerosis. Welcome, Dr. Spurlock.
Thank you for having us.
Oh, so honored to have you here. We have really been looking forward to this interview. We have so many questions from our followers on this new blood test. Now, multiple sclerosis can be difficult to diagnose. Symptoms are nonspecific and mimic other diseases. What do the IQ Isolate test measure, Dr. Spurlock?
Yeah, so, thanks again for having us and for the opportunity to discuss our technology. And at the heart of these tests is a focus on RNA. And RNA is something that you may or may not have heard of. And it allows you to determine a real-time snapshot of what's happening inside the cells at any given moment. And so our testing looks at RNA expression, and it looks at how your genes are turned on or turned off, and it looks for patterns. And we've identified certain RNAs that are indicative of MS or are consistent with MS in our research. And there have been significant, computer advances over the past 5 or 6 years even. And we've harnessed those advances and in the technology referred to as machine learning. And when we look at our data sets and we look for patterns, we can pull out an MS pattern with very high levels of accuracy, greater than 90%. For multiple sclerosis. And what we find is that this provides a new level of information that providers haven't had access to before. And we all know that MS is a clinical diagnosis, and doctors are trying to put a story together about whether or not the clinical signs and symptoms, as well as imaging studies and laboratory investigations, are consistent with multiple sclerosis or not. And invariably, this takes time, as you alluded to, and we're trying to do all that we can to get information into the hands of these providers who are making these decisions. So this is another tool in the toolbox that they can use as they try to diagnose their patients.
So your test would not replace the traditional MRI and spinal tap?
I think that with any new technology, it's another tool in the toolbox, and this is a new innovation, and it's information that they haven't had access to before now. And we've seen a great evolution in the diagnostic tools for multiple sclerosis, and it ranges from anywhere from clinical signs and symptoms, over 50 years ago, to use of evoked potentials and spinal fluid analysis, to inclusion of the MRI. And this is just another tool that doctors can leverage. And I think that we've researched this for over a decade now. Work was started in the lab under Dr. Tom Awney at Vanderbilt, and this work has reached what I refer to as critical mass, where these RNA patterns that we can detect, provide actionable information. And so I think it's an exciting time to give new information to doctors.
It's with Ekaterina Dobrikova, an expert in cognitive neuroscience and research scientist in the Traumatic Brain Injury Department at Kessler Foundation. She uses the magnetic resonance imaging to examine the influence and performance feedback on learning and how learning through feedback is impacted by depression and fatigue. A recent article by the MS researchers described a new non-pharmacological approach to reduce cognitive fatigue, a disabling symptom reported by as many as 90% of us who are living with multiple sclerosis. Welcome, Dr. Dobrikova.
Hi, thanks for having me.
Oh, it's a pleasure. It's really an honor. Now, Dr. Dobrikova, you were a recipient of a 2016 Switzer Research Fellowship by the National Institute on Disability, Independent Living and Rehabilitation Research, and a 2015 Independent Investigator Grant from the National MS Society. But before we discuss your study on a goal attainment and fatigue, can you explain for our listeners what part of the brain are you imaging in your study?
Sure. So basically, I am specifically focusing on a subcortical structure, so a structure that's deep in the brain. and evolutionarily is an old structure that we share with other animals. It's called the striatum, and that structure has been shown to be involved in a variety of processes, but also in processing rewarding or pleasant outcomes, and in processing motivating stimuli.
What were your objectives with this study?
Well, so we know that from a lot of basic animal and human research, so not applied research, but basic experiments, that the structure, as I previously mentioned, is involved in reward processing, motivation, and learning. But recent clinical studies were starting to show that it might also be involved in fatigue. And again, from basic research, we know that the structure is also heavily involved with a brain chemical called dopamine. It was a gambling task. It might sound funny,
yes.
but we use gambling and we use monetary rewards. So money is usually a very good motivator for a lot of people. And in order to get strong research findings, you need something uniform, where you will see uniform results. So money is one of such stimuli. It doesn't have to be money. I can talk about it later too. So yes, people basically gambled while we scanned their brains, and the gambling task had two conditions. In one condition, people had this opportunity to gamble and win money, and in the other condition, which was a control condition, they did not have this opportunity. So they were basically simply presented with stimuli and had to press a button. And during the gambling or the condition where they had an opportunity to win money, they had to guess a number. So if they guessed correctly, they were told that they won $1, and if they guessed incorrectly, they were told that they lost 50 cents. Each of these conditions, we also asked our participants how fatigued they are, specifically after gambling and trying to get rewards, and after just pressing a button and confirming what they see on the screen. And our participants reported that they had less fatigue, so the levels of fatigue than they reported on a scale from 1 to 10, that number was lower after they performed the reward condition, so where they had the opportunity to win money, and fatigue was higher after the condition where they simply were pressing the button and weren't really engaged in the gambling. Subcortical brain structure, the striatum, was activated more when participants had an opportunity to win money, and the activation was not as strong when they didn't have that opportunity, which is consistent with previous results. So again, this is consistent with a sort of larger basic research literature that indicates the striatum to be involved in reward process. And we also have this result of fatigue now, again showing sort of the convergence of these paradigms.
Now, what overall conclusions were drawn from this study?
Right. So I think, of course, this is, in my view, this is sort of the first potential approach to how we can stimulate the brain in order to reduce fatigue in a non-pharmacological
The interview
way.
is with Christiane Whitehouse of Dalhousie University Department of Psychology and Neuroscience. Welcome, Christiane Whitehouse.
Hi.
It is such a pleasure to have you on the show today.
Yeah, thanks for inviting me.
Oh, our pleasure. And you presented a poster at ECTRIMS 2017 on the impact of depression and anxiety symptoms on information processing speed in multiple sclerosis and other immune-mediated inflammatory diseases. Because the effects of psychiatric comorbidity on cognition in chronic immune-mediated inflammatory diseases are poorly understood. What was the objective of the study?
Yeah, well, I mean, we're really becoming aware that people living with MS are more likely to experience depression and anxiety than people living in the community without MS. And we also know that people living with MS are more likely to show problems in their thinking abilities, or like you said, their cognition. So things like their memory, their ability to pay attention, how quickly they can think through information. So for this study, what we wanted to know how are these symptoms of depression and anxiety and these problems in thinking related or connected to each other. So this is actually the beginning data from a larger study. So this study is going on in Winnipeg, Canada, and we have recruited 1,000 people that are coming in to participate for 3 years, and this is the very first year. So people come in and they complete a lot of questionnaires, a clinic visit, get a lot of information about them, and then they also do these activities that look at their thinking abilities or their cognitive abilities. And so we're able to get scores for them on how they did in these different areas, so in their memory and in their ability to think quickly through information. And we also ask them about, how they report their symptoms or whether they have any symptoms of depression or anxiety, and whether they have a diagnosis of an anxiety or depression disorder.
What were the results of your study?
Yeah, but so the results, the first thing we looked at were, how many people did report these symptoms of depression and anxiety. And in general, we found that in people living with MS and the other groups that more people reported these symptoms than in the general population, or what would be expected based on, what the World Health Organization says is kind of the amount of these symptoms in the population. So we found those to be higher. We also then looked at whether people kind of showed impairment or problems in these different thinking or cognitive areas. So we looked at how quickly process information, how much information someone can hold in their mind at one time, or how quickly they can learn information. And we found that in pretty much all of the areas that we looked at, people with MS more people with MS had problems in these areas than we would expect in the general population.
Is Dr. Bianca Weinstock-Gutman, professor in the Department of Neurology in the Jacobs School of Medicine and Biosciences at the University of Buffalo, and a physician with MB/MD Neurology. Weinstock-Gutman is widely known as a leading expert on MS in adults and children, the executive director of the New York State Multiple Sclerosis Consortium, one of the nation's largest MS registries. She has pioneered new therapies and interventions to treat the disease while helping to develop a more nuanced understanding of the many ways MS affects patients. Her research includes studying the cholesterol link to the MS, bone health, and exercise programs for aging MS patients, and biomarkers that may help predict improved quality of life for patients. She also directs the Pediatric Multiple Sclerosis Center of Buffalo. Welcome, Dr. Weinstock-Gutman.
Thank you.
It's wonderful to have you here. Now, with the approval of Ocrevus last year, it's an exciting time for those living with primary progressive multiple sclerosis. We're finally being included in treatment trials. Doctor, what are the other medications in trials for the treatment of PPS, and do any of them show real promise?
So there are newer medication now tried on primary progressive that's considering to do what we're calling a different mechanism of action than the rest that ocrelizumab is part of it, meaning the anti-inflammatory. We're looking primarily in preventing neurodegeneration, meaning loss of tissue and eventually repair. So there are two ongoing studies today. One is actually finished the phase 2 trial. It's called Ibudilast. It's an oral medication. It is also shown benefit on from Japan, benefit on asthma. And the study was, the results of the study were presented, part of it, at the ECTRIMS.
Yes.
They're ready to be sent to publication in New England Journal, and hopefully they'll make it. It's considered to be a product that may protect the tissue.
Oh.
And it's included in secondary and primary progressive patients, so progressive patients. The primary outcome was based on the MRI, so preventing the brain atrophy, so the shrinking of the brain, and it did meet the primary outcome. The number of the patients, when we're doing studies, we're trying to determine how many patients can get in, and they to show a benefit.
Mm-hmm.
So this was based on MRI data and not on clinical data that may require more patients. So on the progression, what we're measuring with the scale we're calling EDSS did not show benefit. And another measure, we looked for the measures of the optic nerve. It's the so-called OCT, optical coherence tomography. We didn't see much benefit either. But the primary outcome, based on which the number of patients were included, it did reach benefit. So that is something that we'll probably look forward for a phase 3 trial, with larger sample of patients, and eventually looking for FDA approval. And the second one is the high-dose biotin.
Mm-hmm.
The high-dose biotin also will include secondary and primary progressive. It's an ongoing trial, multi-center, that biotin is a vitamin B7, but in a very high level as related to, as compared with what we have on the shelves. We do use biotin for hair and nails and, skin benefits. So over there you can find on the shelf on different measure. You find it in 1,000, 5,000, 10,000, but it is micrograms. The dosage used for the study is 100 milligram 3 times a day, so 30 times more than maximum. So it's an ongoing trial. The phase 2 did show preliminary benefit and actually improving the disease, considering that may have an impact on remyelination and repair.
That would be wonderful. Yes.
So we're waiting for the results. There are many patients that are using it as obtaining it from compound pharmacies.
Yes. That's really popular.
You still have to be careful, though. There is certain consideration, even on the study, that included patients still on therapy, although there is still a question about the existing medication, if they had any effect on patients already progressing. But around 25% of these patients were on medication. But there was only the first line, the injectable, Copaxone and interferons. So the analysis was not, divided on whoever was on medication or not. But it's considered to eventually be as an add-on if considered. It's not only medication alone.
Yeah, it wasn't the primary treatment. That's very interesting. And the Ibudilast did not have the visual outcomes that, say, Ocrevus has shown. That's interesting as well.
Yes.
Yeah, that's very interesting. So we definitely need to join us again next week here on MS&Me Interviews.